Welcome to the Deep Dive, the place where we cut through the noise and give you the essential knowledge you need, fast but thoroughly.
And today, we are really plunging into an entirely different world.
We are. We're talking about medicine where the environment isn't just a backdrop, it's an active and often brutal participant in patient care.
We're talking about situations where definitive care isn't just an hour away. It can be days.
That's the definition of wilderness medicine, right?
Yeah.
Care delivered when you're more than an hour away from a fully equipped hospital.
It is. But as the sources from Davidson's review really emphasize, that hour, it expands very, very quickly when your patient is up against extreme cold or crushing pressure deep underwater or just thin, unbreathable air.
Exactly. So for this deep dive, we've gone through the medicine in austere environments section of Davidson's, which is just a fantastic resource.
It really is.
And our mission today is to pull out those core physiological concepts, those absolutely high-yield management principles. We're covering extremes of temperature, both hot and cold, plus altitude and subaquatic medicine.
So if you're a learner out there, maybe a medical student, we really want to give you those anchors, those metaphors that make this information stick. Because it's life or death stuff.
It really is. And what's so fascinating, and what the text stressed right at the beginning, is that this field is all about the interaction between the environment and human health.
Right. Before you even get to the patient, it's about situational awareness. It's about thinking about human factors.
What does that mean in practice?
It means prevention is your best medicine. Optimizing your fitness, knowing that frostbite almost always hits the hands and feet, or having a schedule for blister care before it even becomes a problem, it's all proactive.
And it's not just for expeditions anymore, is it? The authors make a really strong point that with global climate changes, the environment is a bigger and bigger factor in disease everywhere.
Absolutely. Extreme weather events are becoming common. So heat stroke or acute cold exposure, that's becoming a real issue for urban and rural emergency rooms all over the world.
So these aren't just exotic fringe topics.
Not at all. They're becoming core public health issues. And to really get a handle on them, we have to start with the fundamentals. We have to understand how the human body, which is basically a tropical organism, fights back.
Let's start with the cold.
Let's do it.
So everything starts with the body's central command for temperature, right? The hypothalamus, our internal thermostat.
That is the absolute core concept. The hypothalamus keeps our core temperature in this incredibly tight range, around 37 degrees Celsius, plus or minus half a degree.
And that's not arbitrary.
No, not at all. It's all about protecting our enzymes. Our whole metabolism depends on those enzymes working perfectly. If you get too far from that set point, especially below 30 degrees, enzyme kinetics just slow to a crawl and everything starts to fail.
And when the environment is trying to steal that heat, it happens in 4 specific ways. The sources call this the heat loss quartet, which is a great way to remember it.
It is. And understanding these 4 is the first step to managing a cold patient.
Okay, so let's break down that quartet. First up is radiation.
Right. This is the simplest one. Think of your body like a little oven in a cold room. You're just radiating heat out into the cooler environment through electromagnetic waves.
And if you're not properly insulated, this can be a huge source of heat loss.
It can be up to 60% of your total heat loss. It's all about the temperature difference between your skin and your surroundings.
Okay, second in the quartet, convection.
The classic metaphor here is blowing on a bowl of hot soup. Your body warms up a very thin layer of air right next to your skin, kind of like a little insulating blanket.
But the wind strips that away.
Exactly. Wind or even moving water constantly removes that warm layer, and your body has to spend more energy heating up a new one. That's the whole principle behind wind chill. It's not actually colder, but you lose heat so much faster.
Number 3 is evaporation.
This is a big one. It takes a huge amount of heat energy to turn water from a liquid into a gas. We lose heat from sweating, obviously, but also just from breathing.
And this is where getting wet becomes so dangerous.
Yes. If you work up a sweat in the cold or your clothes get wet from rain or snow, that moisture starts to evaporate and it just sucks the heat right out of you. It's a massive risk factor.
And finally, number 4, conduction.
This is direct heat transfer, touching a colder object. So lying on cold ground, sitting on a metal bench.
The ground just acts like a giant heat sink.
It does. Air is a pretty poor conductor, but solid ground or water, they're excellent conductors. They'll pull heat out of you incredibly fast, which is why ground insulation is so critical for survival.
So once the hypothalamus detects that we're losing heat, it triggers the first-line defenses through the sympathetic nervous system, What happens then?
The body goes into lockdown. Core protection mode. It does three things right away.
Okay.
First, you get cutaneous vasoconstriction.
Okay.
It pulls blood away from the skin in your hands and feet to keep the core warm. That's why you get pale.
Second.
Increased heart rate, increased contractility. The heart starts working harder. And third, and most obviously, shivering.
Which is really just the body trying to generate its own heat.
Yep. Exactly. Shivering is incredibly effective at first. It can increase your basal heat production by 2 to 5 times, but it's also really, really expensive metabolically.
And this leads to a critical turning point. The moment the shivering stops, that's a huge red flag, isn't it?
That is the single most important physiological sign you can see in the field. It means the body's adaptive mechanisms have been completely overwhelmed.
At what temperature does that happen?
It stops somewhere between 29 and 31 degrees Celsius core temperature. Once that happens, the patient is sliding into moderate or severe hyperthermia, and they have no ability to generate their own heat anymore. They are 100% dependent on you.
Okay, let's dive into what happens as that core temperature keeps dropping. It's described as this dramatic physiological slowdown.
It's a near-total systemic shutdown. For every 1 degree drop in core temperature, your oxygen consumption, your whole metabolic rate drops by about 6%.
So everything is just happening in slow motion.
Everything. Every chemical reaction, every heartbeat, every breath. Your breathing slows down, not just because the drive from the brain is lower, but because your slowing metabolism isn't producing as much CO2 to trigger a breath.
And the body's trying to protect the core with that vasoconstriction, but that creates its own problems, almost like a secondary shock.
That's a perfect way to put it. The body is shunting blood away from the periphery, and the kidneys get hit the hardest. The vasoconstriction there is so profound that it actually looks like the patient is in hemorrhagic or septic shock.
So they're not getting enough blood flow.
Not at all. It leads to what's called cold diuresis at first, and then pretty quickly acute kidney injury.
And what about blood sugar? The sources mention hyperglycemia, which seems a bit weird if metabolism is slowing down.
It does seem counterintuitive, but it's a stress response. The body dumps stress hormones, cortisol, catecholamines, and they trigger the liver to release glucose.
But the cells can't use it.
Right. Insulin is basically useless in the cold. The cells can't take up the sugar effectively, so you end up with high blood sugar. But the body is starving at a cellular level. It's another sign of just how dysfunctional everything has become.
And all of this is setting the stage for the biggest danger: cardiac arrhythmias. Can you walk us through the fluid shifts and how they lead to an unstable heart?
So as the body cools, plasma volume drops. Fluid moves out of the blood vessels and into the cells because the cell membranes get leaky.
Worsening the shock state.
Exactly. But the key to the arrhythmias is potassium. Below about 25 degrees Celsius, the sodium-potassium pumps in the cell membranes start to fail.
Okay.
This leads to a drop in intracellular potassium, which makes the heart muscle cells incredibly irritable and prone to firing spontaneously. This is what sets the stage for those lethal arrhythmias.
So the whole system is just teetering on the edge.
Cardiac output plummets. Your heart rate is basically cut in half by the time you hit 28 degrees. And then the electrical chaos begins. It's a predictable and deadly progression.
Sinus bradycardia.
Then slow AF, and then the one we all fear. Ventricular fibrillation, VF.
And this brings us to probably the single most important takeaway for anyone working in the cold: the 30-degree danger zone.
This is it. This is the reason you must handle these patients with extreme care. Below 30 degrees Celsius, that cold, irritable heart can be tipped into VF by almost anything.
You mean just by moving them?
Yes. Excessive stimulation, rough movement, even just sitting them up too quickly. It can cause a little surge of adrenaline that's enough to trigger that fatal rhythm. You have to handle them like they're made of fragile glass.
And neurologically, we're seeing a similar decline: slurred speech, confusion, then unconsciousness around 28 to 30 degrees.
And that's also where you can see that bizarre phenomenon of paradoxical undressing.
Where people start taking their clothes off because they feel hot.
It's thought to be a failure of the central thermostat, maybe a final massive rush of warm blood to the skin right before they collapse, giving this false sensation of warmth.
But what's really amazing, and what gives us hope in these cases, is this idea of neuroprotection from the cold.
It's the ultimate paradox. The cold is killing the body, but it might be saving the brain.
How does that work?
Below 20 degrees Celsius, the brain's electrical activity pretty much stops. The brain's metabolic demand for oxygen just plummets.
It's like putting it in hibernation.
That's a great analogy. The cold stabilizes the cell membranes. It protects the blood-brain barrier from the damage of hypoxia. So if the brain gets cold fast before it gets starved of oxygen like in cold water drowning, it's essentially preserved.
Frozen in time.
Exactly. And that's the physiological basis for those truly miraculous survival stories you hear about.
Okay, so that brings us to management. In the field, getting an accurate core temperature is really tough. Rectal thermometers lag, ear thermometers are useless.
And a lot of standard thermometers don't even read that low.
Right, so clinical staging is everything. And the Swiss staging system gives us a really practical, symptoms-based way to do that.
It's an essential tool. It lets you know how sick your patient is and what you need to do without needing any fancy equipment.
So let's run through the 4 stages. Stage 1.
HTI, that's mild hypothermia between 32 and 35 degrees. The key signs are the patient is alert and shivering. The body is still fighting.
And the management is pretty straightforward.
Get them to a warm place, give them warm sugary drinks, get them into dry clothes, and this is key, encourage active movement. Walking around can generate a ton of heat.
Okay, stage 2.
HT2, moderate hypothermia, 28 to 32 degrees. And here's the change. The patient is drowsy and has stopped shivering.
That's the alarm bell.
That's the huge alarm bell. The body has failed. The risk of VF is now very real, so management changes completely.
No more active movement.
Absolutely not. You keep them horizontal, you handle them gently, and you focus on insulating them completely. You can use external warming packs, but only on the core, the armpits and groin.
Then we get to stage 3.
HT3, severe hypothermia, 24 to 28 degrees. The patient is unconscious, but they still have vital signs.
In stage 4?
HTIV, cardiac arrest. Below 24 degrees, unconscious, no vital signs.
And for stages 3 and 4, we're talking about active, invasive rewarming, which is usually a hospital-level intervention.
It is, because things like forced air blankets are just too slow. They might only raise the temperature by a degree or 2 per hour.
You need to heat the core directly.
Right. So you can start with things like bladder or thoracic lavage, circulating warm saline inside the body. That gets you a few degrees per hour.
But for the sickest patients, especially those in cardiac arrest, there's a gold standard.
ECMO, extracorporeal membrane oxygenation, or cardiopulmonary bypass. You're basically taking the blood out of the body, warming it, oxygenating it, and putting it back in.
And that's much faster.
It's the fastest method by far. You can get 6 to 10 degrees of rewarming per hour. It's an incredible life-saving technology.
Now, this brings us to the really critical changes to the standard cardiac arrest algorithm when a patient is this cold.
The rules completely change. First off, you need to do an extended check for signs of life. Check for a pulse and breathing for 1 full minute.
Because everything could be that slow.
So slow, it's almost imperceptible. Don't pronounce someone dead until you've done a proper check.
And defibrillation is different too.
Very different. You give 3 initial shocks if they're in VF. If that doesn't work, you stop. You delay any further shocks until the core temperature is back above 30 degrees.
Why is that?
Because the cold heart is refractory to electricity. The shocks won't work, and you'll just end up causing more damage to the heart muscle.
And what about drugs like adrenaline?
You withhold all drugs below 30 degrees. The body can't metabolize them, so they just build up to toxic levels. Between 30 and 35, you give them, but you double the time between doses.
All of this is based on that one powerful idea.
Yeah.
You're not dead until you're warm and dead.
And the case reports are just astounding. That skier in Norway found at 13.7 degrees who survived after 9 hours of CPR. It just completely resets what we think is possible.
But there have to be limits. There are markers of futility, right? When do you know the resuscitation is just not going to work?
There are a few. If there's an obvious lethal injury, that's one. Or if you know there was prolonged asphyxia, like being buried head down in an avalanche.
And there's one blood test that could be definitive.
A serum potassium level above 12. If the potassium is that high, it means there's been massive, irreversible cell death. And at that point, unfortunately, survival isn't possible.
Okay, that was a huge amount of critical information. Let's just pause here for a moment and really lock in the most important action.
Good idea.
We've just gone through the whole spectrum of hypothermia. So imagine you're out there and you find someone who is unconscious and no longer shivering. You have to move them. What is the single biggest mistake you have to avoid, and what's the temperature threshold that drives that caution?
And if you didn't immediately think gentle handling to avoid VF below 30 degrees Celsius, this is a really good time to rewind and listen to that cardiovascular section again.
Yeah.
It's one of those things that can literally save a life.
Absolutely. Now, Let's shift from the whole body being cold to just parts of the body. Localized cold injuries.
Right. And we need to separate these into two very different things. Frostbite, which is a freezing injury, and non-freezing cold injury.
Let's start with frostbite. This is where ice crystals actually form inside the tissue.
And it overwhelmingly happens in the hands and feet in about 90% of cases.
The mechanism is really interesting because the damage happens in two phases.
It does. Phase 1 is the freezing itself. The ice crystals cause direct mechanical damage to the cells. But phase 2, which is actually the more destructive phase, happens during rewarming.
It's a reperfusion injury.
It's a massive reperfusion injury. The circulation returns, but it brings this huge inflammatory cascade, fluid leakage, and lots of clotting. That's what causes the real tissue death.
And that two-phase process leads to the absolute #1 rule of frostbite management.
Rewarming must only ever be started if there is absolutely zero risk of refreezing.
Why is the thaw-refreeze cycle so much worse?
Because it multiplies the damage exponentially. You get way more inflammation, way more cell death. It's far better to walk out on a frozen foot than to thaw it and have it refreeze halfway. That's a limb-losing mistake.
So in the field, once you're sure it's safe to thaw, what's the plan?
You get them warm, dry clothes, warm drinks, and the sources recommend two specific medications right away.
Aspirin and ibuprofen.
Exactly. Aspirin to fight the clotting, and a high dose of ibuprofen to fight that massive inflammatory response. And you never, ever rub the area with snow or apply direct heat.
Right, because the tissue is numb and you could cause a severe burn.
You could. Once it's warmed, you treat it very gently. And the definitive rewarming is done in a hospital with circulating water, kept between 37 and 42 degrees.
Now let's contrast that with non-freezing cold injury. Cringe foot.
This is a totally different beast. This is from prolonged exposure to cold, damp conditions, but the tissue never actually freezes. It's an injury of chronic ischemia from severe prolonged vasoconstriction.
And the presentation is different.
The limb is numb and pale, but when you rewarm it, it becomes incredibly swollen, red, and intensely painful.
And the management is different too. With frostbite, you rewarm rapidly. What about here?
Here, you rewarm gradually. Rapid rewarming causes excruciating pain, and that pain can be incredibly difficult to treat, often lasting for months or even years. It's a neuropathic pain that usually needs drugs like amitriptyline.
Okay, let's flip the switch entirely.
Yeah.
From the cold to the heat.
An environment that, as we said, is becoming a bigger threat to more people every year. The WHO numbers are staggering.
They are. So we need a clear framework. And the thermal ladder is a good way to think about the spectrum of heat illness.
It is. It helps you see the progression from something benign to a true medical emergency.
So starting at the bottom of the ladder, we have heat edema.
Right. Just some mild swelling in the feet and ankles when you're first exposed to heat. It's from vasodilation, fluid pooling. It's self-limiting.
Next rung up, heat cramps.
Painful muscle spasms. But these aren't really from the heat itself. They're from losing a ton of salt through sweat and then only replacing that fluid with plain water.
So you're diluting your electrolytes.
Exactly. A little salt replacement, and they go away quickly.
Then we have heat syncope.
Just a simple faint. All that vasodilation to get rid of heat means blood pools in your legs when you stand up too fast. Usually pretty benign.
Okay, now we're getting into more serious territory. Heat exhaustion.
This is where you have significant volume and salt depletion. You feel terrible headache, nausea, weakness. You're sweating profusely.
But here's the absolute key distinction we need to anchor.
Your mental status is normal. You might feel awful, but you're still thinking clearly. Your central nervous system is still compensating. In a way, it's a protective state. It forces you to stop.
Before you hit the top of the ladder,
Yeah.
which is heat stroke.
The true medical emergency. And the definition has two parts that you have to remember.
Neurological impairment.
So confusion, aggression, seizures, loss of consciousness.
And a core body temperature of 40 degrees Celsius or higher.
And you have to measure it rectally. That's the only reliable way. And remember, they might still be sweating. The idea that heat stroke patients are always dry is a myth, especially in exertional cases.
Davidson's puts a big emphasis on prevention, which means understanding the risk factors.
And the single biggest, most modifiable risk factor is hydration. The data is just crystal clear on this.
A 2 to 3% drop in body weight from fluid loss is enough to impair performance.
It is. It raises your core temperature for any given amount of work.
Yeah.
The military has very specific guidelines for fluid replacement based on how hard you're working.
And it's not just about the temperature on the thermometer, is it? Humidity is a huge factor.
It's massive, and that's why we use the wet bulb globe temperature, or WBGT. It's a much better measure of heat stress because it combines temperature, humidity, wind, and even solar radiation.
Because if it's too humid, your sweat can't evaporate.
And if your sweat can't evaporate, you've lost your #1 cooling mechanism. The risk just skyrockets, even at moderate temperatures.
Other big risk factors are things like obesity and, of course, a lack of acclimatization.
Climatization is so important. It takes at least 8 days of mild exercise in the heat for your body to adapt. You sweat more efficiently, you lose less salt. Your body just gets better at cooling itself.
So let's talk about the pathophysiology of heat stroke. It's often compared to severe sepsis or major trauma.
And that's a really good analogy because the damage is happening on two fronts. You have direct damage from the heat itself, and you have widespread organ damage from a lack of blood flow.
At a cellular level, what's going on?
It's catastrophic. At
Yeah.
40 degrees, enzymes start to denature. At 41 degrees, your mitochondria, the powerhouses of the cell, just stop working. The gut and the muscles are usually the first to go.
And systemically.
The body tries to compensate with this massive vasodilation to shunt blood to the skin. Peripheral blood flow can go up to 8 liters a minute,
That puts a huge strain on the heart.
a tremendous strain. And it can lead to cerebral edema, acute liver and kidney failure, and critically, DIC disseminated intravascular coagulation.
Which is where you get uncontrolled clotting all through the small blood vessels.
Exactly. It chews up all your clotting factors, so you start bleeding elsewhere. It's a sign of total systemic collapse and a very bad prognostic indicator.
So given that the damage is directly related to how long and how high the temperature is, the management anchor is simple and non-negotiable.
Cool them down immediately.
Speed is everything.
The goal is to get their core temperature down to around 39 degrees as fast as humanly possible. And understanding the different cooling rates is key to choosing the right method.
Okay, let's compare them. What's the fastest?
The undisputed champion is ice water immersion. Tossing them in a tub of ice water, you can get cooling rates of up to 0.35 degrees per minute. It's incredibly effective.
But not always practical in the field. So what's the next best thing?
Evaporative cooling. You strip them down, you spray them with lukewarm water, and you get a fan on them.
And you combine that with ice packs.
Yes. Placing ice packs on the major blood vessels, neck, armpits, groin, makes it even more effective. These mechanical methods are just vastly superior to, say, just moving someone into an air-conditioned room.
And what about giving cold IV fluids?
It helps a little. Cold saline at 4 degrees can drop the core by about a degree over 30 minutes, but its main job is to support their circulation, to replace the volume they've lost. It's supportive care, not the primary cooling method.
So the focus has to be on external mechanical cooling.
Always. And it's worth noting that things like dantrolene, which is used for malignant hyperthermia, have no role here. This is a different pathophysiology.
Okay, time for another check-in on a high-stakes scenario.
Let's do it.
You're at the finish line of a marathon. A runner collapses. They're confused. Their core temp is over 40. You have ice, water, and a fan. Based on what we know about cooling rates, what's your immediate plan of action?
And if you hesitated for even a second, you need to remember that at 41 degrees, their mitochondria are shutting down. Every minute counts. The answer is to get them wet, get the fan on them, and pack their groin, neck, and armpits with ice, or get them into an ice bath if you can.
Right. Let's move to our third environment, high altitude.
So now we're talking about altitudes above 2,500 meters, or about 8,000 feet, a completely different set of physiological challenges.
And the physics here is the absolute key. It's not that there's less oxygen in the air, is it?
That's the most common misconception. The percentage of oxygen is always 20.9%. What changes is the barometric pressure. It drops dramatically as you go up.
And since the partial pressure of oxygen, the PO2 is what drives oxygen into your lungs, that's the number that matters.
That's everything. At the summit of Everest, the PO2 is only about a third of what it is at sea level. So you're in a profoundly hypoxic environment.
And the body's immediate response is to hyperventilate.
You start breathing faster and deeper to try and pull in as much oxygen as you can, but this has a major side effect.
You blow off too much carbon dioxide.
You do, and that leads to respiratory alkalosis. Your blood becomes too alkaline.
And that causes its own problems.
Initially, yes, that alkalosis shifts the oxygen-hemoglobin dissociation curve to the left.
Meaning, Your hemoglobin holds on to oxygen more tightly, so it's harder to release it to the tissues.
Exactly. But with acclimatization, the body corrects for this. The kidneys start excreting bicarbonate to create a metabolic acidosis, which pushes the curve back to the right where it should be.
But the real danger is where you're living on that curve.
Yes. At sea level, we're on the flat top part of the curve. You have a huge buffer. A little drop in PO2 doesn't change your oxygen saturation much at all.
But at altitude, you're on the steep part.
You're living on the edge of a cliff. Now, any small drop in PO2 from a little bit of exercise or even just falling asleep causes a huge, immediate, and potentially dangerous drop in your oxygen saturation. Your safety margin is gone.
So we've got this trio of high-altitude illnesses, AMS, HACE, and HAPE, that are all caused by going up too fast.
It's all about ascending faster than your body can acclimatize. Prevention, a slow, controlled ascent, is by far the best treatment.
Let's start with the most common one, acute mountain sickness, or AMS.
The common cold of the mountains. It affects more than a third of people who go above 3,000 meters. The symptoms are really nonspecific: headache, nausea, fatigue, can't sleep.
And the underlying cause is increased pressure in the skull.
Right. Hypoxia makes the blood vessels in the brain dilate, which leads to a bit of fluid leak and increased intracranial pressure. That's what causes that classic pounding altitude headache.
Mild AMS you can just treat with rest and hydration. But if it's worse, we have a couple of key medications. Let's start with acetazolamide.
This is a cornerstone of altitude medicine for both prevention and treatment. It's a carbonic anhydrase inhibitor.
How does it work?
It makes your kidneys excrete bicarbonate. This forces your blood to become more acidic. It induces a metabolic acidosis.
Which counteracts the respiratory alkalosis from hyperventilating.
Precisely. And that acid state stimulates your brain to breathe deeper and faster, which improves your oxygenation and speeds up acclimatization. It's a brilliant physiological hack.
And the other drug is the steroid, dexamethasone.
Dexamethasone is more of a rescue drug. It reduces the swelling and fluid leak in the brain, which improves the symptoms and buys you time to get down safely.
Which brings us to the next, much more serious condition. High-altitude cerebral edema, or HACE.
This is a life-threatening emergency. The diagnosis is AMS symptoms plus one of two key neurological signs: ataxia, the inability to walk in a straight line, or cognitive impairment.
And it can progress incredibly fast.
From ataxia to coma in less than 24 hours. It's terrifying.
So management has to be immediate.
Descent. Descent is the only real treatment. It is non-negotiable. You give dexamethasone to stabilize them, but you have to get them down now.
And finally, the biggest killer at altitude. High-altitude pulmonary edema, or HAPE.
This is fluid in the lungs, but it's not from inflammation like a normal pneumonia. It's a pressure problem.
Explain that.
Hypoxia causes the blood vessels in the lungs to constrict, but this constriction is patchy, it's uneven.
So you're forcing the entire cardiac output through fewer open vessels.
Exactly.
Yeah.
This creates pockets of incredibly high pressure in the pulmonary capillaries. That high pressure physically damages the capillaries and forces fluid to leak out into the air sacs.
And the symptoms start with a dry cough and shortness of breath with exertion.
And then it progresses to a wet, gurgling cough, maybe pink, frothy sputum, and severe shortness of breath even at rest.
And the management, once again, is simple.
Get down. Immediate descent of at least 1,000 meters is life-saving. That and supplemental oxygen. No drug has ever been shown to work better than descent and oxygen.
Okay, let's do a quick check-in on the pharmacology here.
Okay.
When you're treating someone with AMS, what's that key drug we use, and what's the physiological mechanism it uses to drive ventilation?
You should be thinking acetazolamide and its job of creating a metabolic acidosis to fight the respiratory alkalosis. If that's not clicking, it's worth a quick review.
All right, on to our final environment. Underwater, subaquatic medicine.
Where we face both cold and the immense, inescapable physics of pressure.
Let's start with drowning. The definition is simply respiratory impairment from being in a liquid.
And the process is pretty consistent. You hold your breath, then your larynx spasms shut to protect your airway.
But eventually, the drive to breathe from rising CO2 becomes overwhelming.
It does. The laryngospasm breaks, and you aspirate some amount of liquid.
Now, we're often taught about the big difference between saltwater and freshwater drowning. How important is that, really?
Clinically, not as much as you'd think. Yes, saltwater is hypertonic and pulls fluid into the lungs, while freshwater is hypotonic and gets absorbed into the circulation. But they both end up doing the same thing. They wash out surfactant, damage the alveoli, and cause profound hypoxia. Significant electrolyte shifts are actually quite rare.
The real killer, especially in cold water, is something else entirely.
The cold shock response. This is what's believed to cause the vast majority of drowning deaths.
What is it?
Sudden immersion in cold water, it's maximal between 10 and 15 degrees Celsius, triggers this uncontrollable reflex gasp for air.
The gasp of death.
It can be. It's followed by uncontrollable hyperventilation. It just destroys your ability to hold your breath, and you can aspirate water within the first 30 seconds, long before hypothermia could ever set in.
And if you survive that, you face another danger. Autonomic conflict.
This is a fascinating and deadly phenomenon. The cold water on your face triggers the diving reflex, which is vagal, and causes your heart to slow down bradycardia.
But the panic and cold shock are causing a massive sympathetic surge, trying to speed your heart up.
And you have these two powerful opposing signals hitting the heart at the same time. It's incredibly arrhythmogenic and can lead directly to VF and sudden death.
So for management, rescuer safety is number one. Reach, throw, row, don't go. But once you get the person out, how you move them is really important.
You have to keep them horizontal. If you pull them out of the water and stand them up, the loss of that hydrostatic pressure from the water can cause all the blood to pool in their legs, leading to sudden circulatory collapse.
And what about CPR? Drowning is a hypoxic arrest, not a cardiac one.
Exactly. So the algorithm changes. You start with 5 initial rescue breaths before you even begin chest compressions to try and reverse that profound hypoxia.
And we see that neuroprotection idea come back here too.
It does. Submersion in really cold water, less than 6 degrees Celsius, can be profoundly neuroprotective, and that's why the futility guidelines are different.
Resuscitation might still be reasonable after 90 minutes of submersion in ice water.
It might. It completely changes the calculus.
And for someone who had a near drowning but seems okay, how long do you watch them?
6 to 8 hours of observation is the standard. You're watching for delayed pulmonary edema. If they're fine after that, with a normal chest x-ray and blood gas, they can usually go home.
Okay, let's finish with diving medicine, which is all about the gas laws.
It's pure physics, and you have to understand 2 laws, Boyle's law and Henry's law.
Let's start with Boyle's.
Boyle's law says that the volume of a gas is inversely proportional to pressure. As you go down, pressure increases and gas in your body compresses.
But the danger's on the way up.
Always on the ascent. As you come up, the pressure decreases and that gas expands. If you hold your breath on ascent, the expanding air in your lungs can rupture your alveoli. That's barotrauma.
And that rupture is what leads to the most feared diving emergency, arterial gas embolism, or AGE.
Yes, the air from your ruptured lung gets forced directly into your arterial circulation. Bubbles go straight to your brain. It happens immediately on surfacing and causes sudden, catastrophic neurological symptoms, seizures, stroke, unconscious death.
Okay, now for the second law, Henry's law.
Henry's law says that the amount of gas that dissolves into a liquid is proportional to the pressure.
So as a diver goes deeper, more nitrogen from the air they're breathing dissolves into their blood and tissues.
Exactly. The body gets saturated with nitrogen. The problem again is on ascent. If you come up too fast, the pressure drops, and that dissolved nitrogen comes out of solution and forms bubbles, like opening a shaken soda can.
And that's decompression sickness or the bends.
That's it. Those bubbles can form anywhere, in your joints causing pain, in your spinal cord causing paralysis. The symptoms are more gradual than AG, usually minutes to hours after the dive.
And the management for both AG and DCS is the same. What's step 1?
100% oxygen, immediately. This creates a steep gradient to help wash out the nitrogen from the body.
But the definitive treatment is recompression.
The gold standard, you put them in a hyperbaric chamber, increase the pressure again. This physically crushes the bubbles back into solution via Boyle's law and floods the tissues with oxygen.
Fascinating. Just a pure application of physics to medicine.
It really is.
Okay, that was an incredibly dense but critical journey through some extreme physiology. Let's wrap it up with the 4 big, non-negotiable takeaways.
Sounds good. Number 1, hypothermia. Remember the 30-degree threshold. Below that, gentle handling is everything to prevent VF.
Number 2, heat stroke. It's defined by neurological impairment and a temp over 40 degrees. The only priority is immediate, aggressive cooling. Ice water immersion is best.
Number 3, altitude illness. For HACE and HAPE, descent is the only cure. And remember acetylzolamide's trick? Creating a metabolic acidosis to drive ventilation.
And number 4, dive medicine. It's all about Boyle's law causing barotrauma and AGE on ascent, and Henry's law causing DCS. The treatment for both is 100% O2 and recompression.
That's the core framework, knowledge that really hinges on understanding physics and physiology.
Knowledge that you can apply whether you're in a busy ER or on a remote expedition. And that leads us to our final provocative thought for you to chew on.
We spent all this time talking about how the cold is a killer. But then we have these cases.
Yeah.
Like the person who survives 9 hours of CPR at a core temp of 13.7 degrees.
How does that level of neuroprotection challenge our standard ideas of irreversible death? When does the environment stop being just the hazard that's trying to kill you?
And become this strange, temporary biological safety net that can literally suspend the rules of life and death.
Something to think about.
Thanks for diving deep with us.
We'll see you next time.